All right, welcome everyone to the next plenary session at CCH's Housing Equals Justice Annual Training Institute. I'm very excited about this next session, which will feature Bobby Watts from the National Healthcare for the Homeless Council, and it's entitled COVID-19 Systemic Racism and Homelessness. On the next slide. So as many of you know, this is our 18th annual training institute that we've conducted. This year, we're doing this as a week-long virtual event. I hope you've all been joining the sessions on Monday, Tuesday, and this morning. We're having sessions all week long. This year's conference and ATI is centered on the theme of housing equals justice, really focusing on homelessness as an issue of racial justice, economic justice, as well as needing criminal justice reform and intersections. And of course, we are also talking about COVID-19 and homelessness as a health equity and health justice issue as well. Next slide. I want to thank our presenting sponsors for this event, Bank of America and Zillow, who are making this possible. We are making this event free and open to the public for the first time ever, and I really want to appreciate our presenting sponsors as well as many of our workshop sponsors for making it possible to bring this to you with free of charge. Next slide. And also make sure you head over to our ATI website on cch.org, where you can visit our bonfire store, where you can purchase our t-shirts, our face masks, mugs, and other items, including this great mug, as well as other items, so you can show your support for Housing Equals Justice. And finally, with that, I want to, it's really my pleasure and honor to introduce, frankly, one of my heroes in the field of ending homelessness, Bobby Watts, who's the CEO of the National Healthcare for the Homeless Council. The National Healthcare for the Homeless Council, as many of you know, supports the 300 Healthcare for the Homeless federally qualified health center programs and 100 medical respite programs across the country, providing training, technical assistance, policy analysis, and policy advocacy to end homelessness. When I was at the federal government, the National Healthcare for the Homeless Council is one of the strongest advocates for not only forging the stronger connections between housing and health, but really helping us to push the federal government to do all that it could to end homelessness. Bobby himself has more than 25 years of experience in administration, direct service, and implementation of homeless health services. He previously served as the executive director of New York City's Care for the Homeless, one of the healthcare for the homeless programs in New York City from 2005 to 2017. And while he was there, that FQHC agency tripled its size. It added a number of major programs and initiatives, including a shelter for persons with mental illness and women with who are medically frail. And they also became licensed as a diagnostic and treatment center in New York State. He served on numerous boards, government task forces, and work groups. He was an inaugural member of New York State's Interagency Council on Homelessness, where he co-chaired his health committee. He's a graduate of Cornell University and also received his master's in public health from the Columbia University Mailman School and an MS in epidemiology. He's also has a certificate of theological studies from Alliance Theological Seminary in Nyack, New York. I'm really pleased to introduce Bobby Watts, who we gave the very challenging task of talking us through this difficult time when we are facing the perfect storm of the crisis of COVID-19, the crisis of systemic racism, and the crisis of homelessness. So please join me in welcoming Bobby Watts. Bobby.
Thank you so much, Richard, for that gracious introduction. And I just really want to congratulate you and your team for a wonderful, wonderful conference. I'm hoping to be able to tune in for much of it. And I've seen the speakers that have gone before in the program, and I know that everyone has already been given a rich diet of tools and information of how to effect change to serve people experiencing homelessness better. So first slide, and then let's just go straight to the second slide. I was given the topic, as you know, of COVID-19, systemic racism and homelessness, and I'm going to take them in a slightly different order. I'm going to talk about systemic racism and homelessness, and then talk about COVID-19. So the goals for this session are to explore the connection between systemic racism and homelessness, discuss the effects, responses, and opportunities stemming from the unprecedented COVID-19 pandemic regarding homelessness, and then suggest steps that each of us, our organizations, our cities, our COCs, can take towards ending homelessness and promoting equity. Next slide. So want to, when Richard gave me this topic, he said, address these triple epidemics, and he may have known or perhaps not, but that is a really important concept of concurring epidemics that have a synergistic multiplicative effect called syndemics. So syndemic, which is where we are now with COVID-19, racism, and homelessness, are a cluster of, in this case, 3 epidemics that have effect that it multiplies the effect of any one of them. So this was first developed in the 1990s by Merrill Singer, where he was looking at substance abuse disorders, violence, and AIDS, and saw how they fed upon each other, and you had to look at all 3 in conjunction with each other if you were to understand it. So next slide. I will say I am taking a public health approach, so I will be referring to some things in public health terms. Want to just tell you about the council, our mission statement, which is a new one. We went through a strategic planning process and came up at the end of it with looking at our mission statement. And just want to go over some of the highlights for you. It is grounded in human rights and social justice. The National Healthcare for the Homeless Council mission is to build an equitable, high-quality healthcare system through training, research, and advocacy in the movement to end homelessness. A few highlights of that. We start off with human rights and social justice because at our core, we believe that housing and healthcare are human rights, and everything we do stems from that. We also want to make sure that we are always providing high quality services, but also equitable ones. And we really want to change the healthcare system so it can meet the needs of people experiencing homelessness and all people better. And we do that through training, research, and advocacy with the ultimate goal of ending homelessness. And we know that we can't do that alone. So we work in partnerships with organizations like CCEH, National Alliance to End Homelessness, as in the movement to end homelessness, where we are bringing the healthcare lens. Next slide, please. So Richard mentioned that serving our largest membership in our community are healthcare for the homeless programs and medical respite programs. I'll talk more about medical respite programs later, but just to focus a few things about the healthcare for the homeless programs. There are 300, at least one in every state. Hopefully you know if there is one in your city near you, and hopefully you can partner with them. Last year, they served over 1 million people experiencing homelessness. Each one is a federally qualified health center, has to meet all the definitions of community requirements of a community health center. In addition, they have to provide outreach in some form. And sometimes that's done, like my former agency, by putting clinics in shelters, in soup kitchens, in supportive housing, or working with supportive housing providers to meet the needs. Others use street medicine. So in addition to outreach, also have to provide or have an extremely strong linkage to substance use disorder services and mental health services. Next slide. So looking at it from a public health point of view, a big concept is that there are social determinants of health. There are things that affect the health of an individual, and we're looking at it in aggregate, the health of a community, of a nation. And Healthy People 2020, I've taken this from that is put out by the United States Public Health Service every 10 years, where they are setting out the public health goals for the country. So in 2020 was the first time they had a separate chapter on social determinants of health. So among them are 5 that I think are really relevant for us that are place-based. So one of them is economic stability, and included in that is housing instability, education, social and community context. One of those subpoints is discrimination. The US government recognizes that discrimination affects one's health and the health of a community and of a nation. Healthcare and neighborhood and built environment. Next slide. So what affects health? Why is this important? Well, it's understood more than ever that healthcare only accounts for about 20% of a person's or a population's health status. Much of the other things that affect their health status our behaviors, their social circumstances, such as the social determinants of health on the previous slide, genetics, and the environment. So it's realized that we have to, if we want to improve the health of our nation, of a population, we can't just look at the quality of the healthcare. We have to look at these other factors as well. In fact, they have more of an impact in aggregate than healthcare. Next slide. So want to just talk a little bit about the importance of place as a social determinant of health. And that is that segregation also adversely affects health because of a concentration of poverty, poor quality housing, and neighborhood environments leads to elevated exposure to stressors such as air and water pollution. And it's these clustering of stressors that impacts a community's health and individuals' health. David Williams is a professor at Harvard. He is year after year, for many years, has been the most widely cited social scientist. And in an article earlier this year in the Journal of American Medical Association, he wrote that social inequities are patterned by place and opportunities to be healthy vary markedly at the neighborhood level. Or as we may have heard, I've heard this a few times on the news, that our destinies are more affected by our zip code than our genetic code. So want to be looking at this as the importance of place in a community. Next slide. So want to address how systemic racism drives homelessness. And I know from some of your speakers, you have hit some of this, some of them will go into more in-depth. So I'll be hitting it at a high level. Next slide. So one thing is to just make sure we're talking on the same terms. So just want to speak briefly of this glossary is from SPARC, which I'll speak a little bit about more later, but it stands for Supporting Partnerships for Anti-Racist Communities, focused just on the homelessness response systems in different communities and how inequity plays a part and what can be done to promote anti-racism homeless response systems in those communities. So one of them is to talk about race and understand that race is not a biological term. It is a social construct. And in fact, from a biological point of view, there is more genetic variation between the social constructed racisms, within a race than there are between them. So racism is a system of power or oppression that's based on race. It's exercised by the dominant group over other groups. So it's not just prejudice, but some define it as prejudice plus power to act on those prejudices in a systematic way. Just want to also hit very quickly structural racism, and it's a system by which the policies and structure of a society or of a system promote racial advantage for one group over another group. I want to speak a minute about privilege, which is really important. And it's the unearned set of advantages that accrue to one, usually the dominant group based upon their race. And important thing in this society that generally is for white people. And many white people have said, I didn't ask for these privileges. That is true. And in fact, many of them are unaware of this set of privileges until it's pointed out. And that's why it's really important that we are clear-eyed and look at society the way it is. The last one I want to talk about is equity, which should be our goal. And equity is a state belonging to, in which, whether you belong to a particular social group or not, it should not affect your outcomes. And it's making sure every group has what they need, the resources and the opportunities to optimize their life. Next slide. So just want to talk very briefly about a super short, give it a very super short history of housing segregation. And I'll just focus on the quote that is first from my mentor, Susan Neitbacher, social worker in New York City. She founded the organization I worked for, Care for the Homeless. She was a founder of the National Healthcare for the Homeless Council. And I was very fortunate that she was my mentor. And one of the quotes that stuck with me is that homelessness is the result of the failure of almost all of society's systems. And just think about that. What has to go wrong to have mass homelessness in the richest country on earth? It's the result of many systems failing. So just want to talk briefly. We know there's been slavery in this country of African Americans. There was Reconstruction, then a period of Jim Crow, which enforced segregation of the races, which systematically disadvantaged African Americans from some of the benefits of this country. And then in housing, one of the key ways that was done is through things that promoted segregation. One of them was racially restricted covenants, which is a part of the housing deed, which states that you will never allow anyone to live in your house who is non-white unless they are your domestic servant. And when you sell your house, you will only sell it to a non-white, you only sell it to someone who is white, and that you would make sure that this deed is in that housing deed which you're selling. So housing segregation did not happen by accident. It's the result of policies, many of them created and backed up and enforced by the federal government. Next slide. So just speaking briefly about the Federal Housing Administration and VA administration. The FHA is the underwriter and guarantor of bank loans for housing mortgages, and really banks would not undertake that, many of them without that guarantee. So they're really making mortgages possible, mortgage loans possible. And they, from the very beginning, the FHA and the VA, the Veterans Administration, only made or guaranteed loans to whites. And so this is federal policy enforcing and creating segregation. And later, in the name of harmonious communities and maintaining property values, they would only lend to African Americans in predominantly Black neighborhoods. And especially in the period after World War II, where suburbs increased and there was a boom in home ownership because of government policies, they would take farmland, developers would come in where there was no community, and they would create communities, and these policies ensured that these new communities that were created were segregated. They would only back developments that had these restricted covenants in them. So housing policy created segregation. Federal housing policy did that. Next slide. So very briefly, the result of this, and I'm just going to center on the middle bullet there, is that Blacks were excluded from the largest government subsidized wealth creation program in history. And because they paid taxes, they helped to fund the programs from which they were unconstitutionally excluded. So whites got the benefit, an unfair advantage, and Blacks got an unfair disadvantage. And think of what that means in a competitive society. Next slide. So I'm going to go through 4 graphs pretty quickly. Don't focus so much on the numbers, but just look at the shape and the slopes. So in this one, this is showing the federal government support to make housing affordable for 4 people as a percentage of the GDP. And it goes from, you can see it starts off really high in 1977 at the end, and then it dropped off precipitously so that by 1982, it was only being funded at about 1/4 of what it was prior to that. Next slide. This slide shows this, basically it shows the same thing over, but using 2017 constant dollars. And it just shows that federal support to make housing affordable for renters, primarily for renters and people in public projects, decreased dramatically, and except for 2 years during the economic stimulus package, it remained low. As my colleagues at the National Low Income Housing Coalition, who I know are part of this conference, pointed out in a blog about 1.5 years ago, and it stuck with me, and I use it. In 1979, it was about $125 billion in 2017 dollars. And you can see in 2017, it was about $50 billion. So what that means, except for 2 brief years, we have systematically and continuously been underfunding support for affordable housing to the tune of $75 billion a year for 40 years. So that is why as you've heard, only 1 out of 4 families that qualify for federal assistance, Section 8 vouchers and so forth, gets it, because we're not funding it. Next slide. This slide shows basically the same thing, but only up to 2004. So it's using 2004 constant dollars. But again, it's the slopes that matter. So the black shows a decrease in support for affordable housing, especially for rentership. But at the same time, we see the red goes up, and this is the federal subsidies for home ownership. So we've decided that we are not going to fund rental support for people who need it, who are poor, but we will promote at much greater cost to the federal treasury, people buying homes, which could be argued, and economists do, don't really need this support. So these are public choices, conscious policy decisions that we've made as a society. Next slide. So this just shows the same thing, US Treasury figures, just showing the top in the the deduction for home mortgage interest deduction is about $1 trillion. It was projected to be slightly different since the new tax law, but compared that to the bottom of 96 billion for credit for low-income housing investments. Next slide. It's just really showing the scope of the lack of our support for making housing affordable for poor people. Want to just look at two other systems. Looked at housing. Want to look briefly at public education and the criminal justice system. So, given the context that we have created racially segregated neighborhoods, and we have denied the chief means for families to build wealth in one, largely based on race, and promoted that for others, which is strongly correlated with race. Public education has been called the great leveler, giving everyone equal opportunity. But in that context, the way that we choose to fund public education, largely based on property values, means that wealthier communities have more to spend and do spend more per student than poorer communities. And the middle bullet shows this is highly correlated with race. And from an equity point of view, if we really wanted things to be more equitable, we wouldn't say that we're going to spend the same. We would say we would spend more on the poorest students who have less advantages in order to level the playing field. But in fact, we do exactly the opposite. Next slide. Looking briefly at the criminal justice history or system, we see that the ones on the left show that the marijuana usage, for instance, for blacks and whites is basically the same, but the arrest rates for marijuana possession are about 3.5 times that for blacks than it is for whites. And this is largely a result of police practices. It is largely based upon place. Which neighborhoods are going to be subject to stop and frisk? Who is more likely to be stopped in a car, and their car, which leads to a car search. So it's not based upon usage, it's based upon police practices. Next slide. And one of the things that has the biggest impact on your future is whether you have been imprisoned. And despite studies that show in many categories, there is no difference between blacks and whites in terms of participation in criminal behavior. We see that for almost all ages, African-American males are 5 times more likely to be imprisoned than an African-American, than a white male. And this is generally a result of biases in the systems, house structures, policing, and so forth. But especially in the early years, which are the most important for setting the course of your life. For those 18 and 19, African-American males are almost 13 more times likely to be imprisoned than their white counterpart. And for those 20 to 24, it's 8 times. So these have huge implications. Next slide. These have huge implications for the health and social health of individuals and race. And unfortunately, it's broken down by race. And just want to point out that people say race is a risk factor. I really like what my colleague Pascal Leon of the Corporation for Supportive Housing said. Race is not a risk factor, racism is. So I want to look now at COVID-19, the COVID-19 pandemic. Look at its effects and responses. Next slide. And not surprisingly, given the context of which, we've just talked about just 3 systems, that we see that there are racial disparities in COVID. And many people have spoken about it. COVID did not cause the disparities, but it exposed what was and exacerbated what was already there. One of the factors is because of education system, more exposure to criminal justice system, differential exposure in the criminal justice system, and also the types of jobs and where people live affects your exposure. So African Americans are more likely to work in essential industries where they did not have the option of staying at home. They're more likely to live in neighborhoods where they need to use public transportation, and they are less likely, as we've said, to own their home, more likely to rent in an apartment where they are sharing elevators, sharing stairwells, sharing hallways. So have less ability to practice social distancing and avoid exposure. Next slide. So Black, Indigenous, and people of color, other people of color are less likely to have health insurance. So that affects their ability to get care, to get preventive care, to avoid expenses connected with that care. Early in the pandemic, African Americans had longer wait times for a test. They were more likely to be treated in an understaffed or poorly served, under-resourced health center. And it reminds me very much, as the pandemic has become more widespread and testing has become more widespread, I'm reminded very much of the early days of the HIV epidemic. Around 1995, the cocktail became known to be effective for preventing progression from HIV to AIDS and to help manage the disease. And it was about a 2-year lag before that became widely available to, in New York City, speaking primarily of my experience as a member of the HIV Planning Council, it became widely available to African Americans and Latinx populations, to drug abusers. So we're seeing that same lag has occurred in terms of the COVID pandemic. And it's long been known there's differential treatment among based on race by members of the health professions. Implicit bias is there, and in this case, it's been expressed that African Americans with similar symptoms that had COVID were less likely first to be tested. Many of them were sent home, and then less likely to get aggressive treatment. There have been studies that have shown that people in the health professions do not take the description of their symptoms with the same degree of gravity as whites. Some studies have shown that ambulance EMT technicians are less likely to give pain medication to an African American complaining of pain than a white. So these are implicit biases, but it laid upon the structural biases and structural racism in our society have huge implications for how COVID affects different people. Next slide. So really want to just show some data. This is from the CDC's website. And just very briefly, we see that in terms of cases, hospitalizations, and death, there's great elevation of all of those for other races other than whites. So for instance, Native American Indians are 5.3 times more likely to be hospitalized than a white person, and African American communities had much higher, twice the, and I'll say, and Latinx communities, more than twice the amount of cases, more than 4 times the rate of hospitalization, and African Americans were twice as likely to die as a white American. Right now, about 1 out of every 1,000 African Americans in this country has died of COVID, of one disease, in 8 months. Just think that 1 out of 1,000 is really, really grave. Next slide. So an important public health concept when we're looking at death rates in particular is to look at adjusted death rates. It's known that as you age, your chances of dying are greater. So you have to adjust by the age distribution of different subgroups. So most of each of these racial minority groups have younger age profiles than whites. So when you take that into account, we'll see that for really all of them, except for Asians, which are 30% more likely to die than a white person from COVID, all the others are 3 times more likely to die. So next slide. So we're seeing the effects of race and racism in our society on health. Speaking briefly about homelessness and health, and I know you had a great presentation earlier today. Just in general, poor health causes homelessness. Homelessness exacerbates existing health problems, and it makes it harder to treat any condition. So for every health condition, the prevalence rates are higher among people experiencing homelessness than their housed counterparts. We see this most seriously in death. And on average, people experiencing homelessness, especially unsheltered homelessness, die earlier. For unsheltered homelessness, they die about 30 years earlier than their housed counterparts. And this is a phenomenon, not the exact numbers, but we see this internationally as well. Homelessness is hazardous to one's health and is deadly. Next slide. So going into the pandemic, many people, including myself, realized that people experiencing homelessness were at grave risk. They have poor overall health to begin with, really greater exposure to the elements, really suffers chronic sleep deprivation, which is often overlooked, but we know the effects of what sleep deprivation does to our health, to our mental health. But whether you're living in a shelter that could be loud and you may be concerned about safety, or you're living under a bridge which is loud and you're concerned about your safety, it's very hard to get a good night's sleep on a regular basis, and people experiencing homelessness suffer from chronic sleep deprivation. So we know that would impact their susceptibility to being infected or to developing an infection, and then also their ability to recover. We also know that people experiencing homelessness have much less ability to practice social distancing and to practice what CDC, one of their top 2 recommendations was to practice hand washing. This epidemic leads to death more among the elderly, and people experiencing homelessness are premature aging, suffer from premature aging. Our clinicians say someone who's 40 years old, been chronically homeless, really has the health of someone 55 or 60. And again, that will affect their ability to resist the disease, both contracting it as well as to fight it off. Next slide. So our society has responded, and communities have responded in ways that are unprecedented to my knowledge. In responding to saying we need to make sure, do what we can to protect the health of our unsheltered neighbors. It hasn't been uniform, it's not universal, but it is more than I remember seeing. So both CDC and HUD made recommendations to shelters on how they can reduce the infection transmission in their facilities, in congregate shelters, and in rescue missions. CDC and HUD recommended removing people who are positive or exposed or who were frail in advance to help protect their health. So a number of alternative care sites were set up, sometimes in an arena where people were able to be spaced out and get care, or also in hotel or individual hotel rooms and motel rooms. CDC also recommended for those who are unsheltered that steps be taken to protect their health. Recommended that cities, and many cities did, put out hand washing stations, portable toilets, place them near encampments or other places where people without homes can use them. That was so important because during the quarantine, people's usual source of getting food, of using bathrooms, libraries, McDonald's, Starbucks, restaurants were all closed down. So this was really important. And CDC recommended that there be a moratorium during this public health emergency on encampment sweeps. They also recommended that people experiencing homelessness be a priority population to receive testing, which, as we know, has been problematic but it is important that we find that. On our website is a project that we're working with CDC, where we've been tracking universal testing data, not when people come to a clinic because they have symptoms, but just when shelters or encampments have been tested, either because they just want to do it in advance, or because there's been one person or two people there where everyone is tested. Next slide. So during this period, and as you well know, there have been new partnerships that have been formed in the midst of this pandemic, on the fly, responding to this crisis. New health partnerships formed with shelters, missions, and/or continua of care, with Department of Health, with local Office of Emergency Management, FEMA, with hospital clinics, HCH programs. Many of them are reaching out to encampments, health departments, and even shelters and rescue missions. And medical respite programs played a big part in helping to respond to the health needs of people experiencing homelessness. And I want to spend some time talking about medical respite for a few minutes. Next slide. So what medical respite is, very quickly, it is a service or a facility for people without homes who no longer have a clinical reason to stay in a hospital, but are too frail and will not heal if they are returned to their prior living condition, or whether that is a shelter or whether that is their friend's couch or the street. So medical respite is a service or a facility that gives them a place to heal. Always case management is provided. The idea is that this will be short-term. It's not a nursing home. It's not long-term, but a place for them to heal, and it also help them stay connected even after they leave to their medical care. And when it works best, it's a bridge to housing. Next slide. So a number of conditions are being treated, but one thing I just want to point out is that these alternative care sites and the need and the recognition that we need to take care of the needs of our neighbor, the health needs of our neighbors without home, was meeting the same goals as medical respite. So that raised the profile of medical respite. Some programs, like the one in Santa Clara, California, was involved. It's run by the public health department, so they were really able to marshal resources, but they spearheaded putting 1,200 people in motel rooms, out of shelters, out of encampments, and maintaining their care while they were there. So it really raised the profile of medical respite. And many communities are saying that we would want that. Just next slide, please. So this is more for health industries, but I think it's also important for you to know that it works. It reduces hospitalization. It reduces returns to the emergency department. It reduces the odds of having to be readmitted into the hospital. Next slide. And I think that is important because I'm going to focus on some of these that are important for shelter providers and housing providers. And I'm bringing my experience as running an agency that ran shelters. I had 2 stints as a shelter director myself, and medical respite is really important, I believe, for the homelessness response system, because it helps to meet the needs for people to be placed in appropriate settings where their needs are going to be met. One of the worst things as a shelter director is when your staff is asked to provide care for patients or clients for which they are not equipped. The physical layout may not be set up for that. Your staff are not trained to meet the health needs. And when you have patients that have these conditions, it makes it hard to operate the shelter. But by medical respite meeting the immediate health needs, it also helps to make sure that people can stay on course with their housing readiness plan, with their independent service plan, so they can keep making progress, so they won't have a relapse and have to go back to the hospital, getting that interrupted. So there are a number of benefits. Next slide. So if you're saying, well, that's great, but we don't have money for medical respite, just really want to point out that medical respite programs are funded by a number of sources, hospitals, philanthropy, Some of the medical services and case management services might be reimbursable depending on the operator by Medicare or Medicaid. And so it's a number of possible funding sources. Next slide. So because of the COVID pandemic, the council, which houses the Respite Care Providers Network, the hub where those 100 medical respite programs exchange information, where we provide training and technical assistance, we receive so many calls from communities asking for technical assistance, and it's asking us to help them expand or improve or establish medical respite programs, that we didn't have the structure to do that, and it was really for people outside, those new kinds of partners. So we established in July the National Institute for Medical Respite Care, and we launched that specifically for the purpose of expanding and promoting medical respite. So this is a copy of our website. It is a special initiative of the council, and our website is up there, www.nimrc.org. Invite you to look at that. Contact us for more information if you'd like. Next slide. So why be anti-racist? One of the solutions to the convergence of these pandemics really is to look at racism. Racism makes each of them makes any and all of them worse. But focusing on equity, I just love the title of your conference and of your campaign, Housing Equals Justice. Being anti-racist in a racist society is promoting justice. Next slide. So just want to refer to a quote from the first SPARC study, came out in March 2018. At that time, I think there were 9 communities. There are many more that said we want to adopt anti-racist practices in our homelessness response system. But what stood out and stuck with me from that report is this quote, is that a bad system always trumps a good program. So if we're saying, why should we try to address racism in our homelessness response system? Justice is one, but also good outcomes. If we want to be changing people's lives, if we want to be setting them up for future long-term success, no matter how good our program is, that program participants' success, if they're a person of color, is going to be limited if we just keep placing them in systems where the odds are stacked against them. So we want to improve their outcomes. We want to improve their lives. And to do that, we need to improve the homelessness response system and from an anti-racist perspective. Next slide. So Ibram Kendi also had some really great quotes, his famous book, How to Be an Anti-Racist. And just to summarize, just want to say that being neutral is not enough. Saying, well, the system is the same, I'm going to keep working within the system, not try to change it, is not enough. As Bishop Desmond Tutu of South Africa said, in an oppressive system, to be neutral is to be on the side of the oppressor. One of the quotes here is that denial is constant. We want to deny, we don't see it, so it's easy to deny. But if we are really going to have better outcomes, we are going to have a much more just society, we have to consistently identify and describe it, and then look at ways to dismantle it. So we're going to talk a few ways that we can dismantle it. Next slide. One, I just really want to emphasize the third and fourth bullet is that as human service professionals, we have the ability and the responsibility to advocate for societal and institutional change on behalf of our clients. And there are concrete steps that we can take in our organization, our city, our department, our team, our continuum of care. Next slide. So I want to give examples of what we can do in homelessness services around this. Next slide. And one of the first things, and this comes from the SPARC report, the top bullet, is just look at our staff and our leadership. And most in the 9 communities that they looked at in the first wave, the proportion of staff, and especially of leadership staff, was not representative of all staff nor of those that they were serving. Whites were overrepresented, especially in leadership. The council has operated 2 learning collaboratives focused on diversity, equity, and inclusion. How can we build those practices into our organizations? It wasn't focused on individual attitudes, but it's focused on organizational structures and practices. And in our first cohort, we had 9 HCH programs and medical respite programs, and it ran for 6 months. And this was the averages from the cohort. And again, especially in the leadership, whites were overrepresented. Now, from an equity point of view, what that means is that it may make it more difficult for the leadership and therefore the organization to understand the dynamics at play in the lives of their patients, of their clients and of their staff of color. We had similar numbers for our second cohort, which started in November of 2019, ran through June of 2020. That one ran for 8 months, had 11 organizations. Most of them were HCH programs and medical respite programs, plus one was a soup kitchen that had a healthcare for the homeless clinic there. And we saw similar things. So first, just to be aware and to understand, well, are we equitable as an organization in how we promote and retain and recruit? Next step. Next slide, please. So some concrete steps. One is to educate our staff. Don't assume that people will automatically say, yes, I agree, we should be looking at racism in our practices, in our structures, and how it is affecting our clients. Educate them. And after that, probably the most important thing is to conduct a race equity assessment of your organization or team. One outcome might be that you create a race equity committee to look at these things on an ongoing basis, and ongoing is important. It does not just be something, oh, we've checked the box since now that we are woke, but it really has to be an ongoing commitment. As someone said, racism in this country did not arise overnight. It's been here for a long time, and it's not going to go away overnight, especially since so much is invisible until you start to look and see where it exists. 2 quick points is to review your policies and procedures from an organizational point, from your patient, I say patient, but from your client's point of view is best. And also do that from the point of view of your staff of color. And to do that, you need their help. And to realize that we will need to advocate for, especially for our clients of color, in the larger system where things are stacked up against them. So we should advocate for changes in our institution, our organization's policies and procedure, and where possible, we should hire, employ, and promote staff with the lived expertise of homelessness. Next slide. So just concrete steps. Really, it's important to collect data on race and ethnicity in your programs and of your staff, and then to use it. One of my favorite examples is of Central City Concern, which is a large organization in Portland, Oregon, that's been working on this for more than a decade. But they looked at their outcome data for some of their programs, and they saw in their employment program, and again, they serve people experiencing homelessness, their employment program, African Americans have poorer outcomes, and in their substance use disorder services, Latinx patients had poorer outcomes. So they went back to the drawing board, designed culturally specific programming for each of them. It's too early to know conclusively, but the preliminary outcomes are this has improved, this has rectified those problems. But the main thing is that they looked and they tried to develop a solution. Next slide, please. So as I conclude, really want to give some of the context and the caveats. One, facing racism in our organization is hard, and it's usually been avoided. And when you start to look at this, if at all possible, you should involve a trained, skilled facilitator or a consultant. As one of them said when I was working on this in my previous organization, said, don't try this without adult supervision. Someone who has done this before, someone who understands. And that is really, really important because this is hard. And there may be difficult conversations, there should be difficult conversations, and our goal should make sure that we create a space where we can have these conversations, discussions in a safe space, create a safe space, not necessarily a comfortable space. And many staff of color may be justifiably skeptical and not want to get involved. Why should they open up their pain, expose their trauma, open up tear the Band-Aid off and tear the scab off, unless they know that that the organization is going to follow through and have a commitment to make things better. So often we see that staff of color don't want to get involved and really do need that follow through. I will say that COCs are uniquely positioned to help address inequity in homeless services. Here in Nashville, the Nashville COC is looking at this. I'm honored to, they recently created an Equity and Diversity Committee. I'm serving as the chair. We have a data committee. Our director of research serves on that as the chair of that committee, and also is the co-chair of the Homelessness Planning Council. So we're bringing from this perspective, there's a lot you can do to help promote equity using the data, which HUD mandates, but also you can really mandate trainings. You can urge organizations to do things. Really want to give a shout out to a document that many organizations have been using, many COCs have been using. I was pleased to see Nashville COC was using it before we pointed out to them that, which is the framework for an equitable COVID response, was put together by 4 organizations: National Alliance to End Homelessness, the National Low Income Housing Coalition, Center for Budget Policies and Priorities, and also the council was part of one of the 4 national organizations, and we brought the health perspective. But it really is looking at, we have an unprecedented opportunity to address homelessness with the CARES Act funding. How can we make sure that's done effectively and in an equitable manner? So this is a great opportunity where people are focused on, where there's more a one-time influx of resources. We have to make sure it's more than a one-time, but that's what we know for right now. And people are more concerned about justice and racial equity following the murders of George Floyd and so many others. It's an opportunity we can't let go to waste. And I'm optimistic that we can make great progress in reaching our country's potential for everyone, so that more people will be housed, more people will be healthy, and more people will be able to reach their full potential as we beat back the darkness of racism in our country. So next slide. What's next? Next slide. I left this blank because the future is ours to write. We can progress along an anti-racist and a more just path, helping our country live up to the full ideals, more of its ideals more fully, help every individual reach their full potential, creating a much just society. We can stay still and do nothing and let the status quo continue, or we could regress. I'm confident that we will choose the path that of justice, but it's up to us to do that. It will not happen by itself. Last slide. Just want to thank you for this great opportunity. Here's our contact information, the council. There's a link there to our anti-racism resource page. We also have a COVID resource page. And I just thank you and for the great opportunity, for the great work that you're doing. And I now turn it back to our moderator, Richard. Thank you for this honor.
Bobby, wow, that was incredible. And, you know, if this were under different circumstances, you'd be in a room full of, I don't know, 500 to 1,000 people, and there you'd be hearing the tremendous applause. I know my head is just swimming with all that you covered in such a short amount of time. And I'm just incredibly impressed at how you were able to weave together the enormous challenges we have. And in particular, I'm struck, Bobby, by the blank slide and your quote that the future is ours to write. And perhaps it is this syndemic, I learned a new term today, syndemic of crises that we're experiencing all at once that might shake us up to do, make that future one that is better and more equitable. So thank you so much. I know there's a couple of questions. We just have a few minutes. I think, first of all, most of the questions coming in are just heaping compliments on you, Bobby, for an amazing presentation. One of the questions, though, is what do you think are the most impactful things a state can do to reduce and ultimately eliminate this inequity? You know, we are a coalition of many homeless services providers, but we pride ourselves in working together as a state. And so what do you think could happen at a state level?
Yeah, thank you. And you know, when we're speaking of equity, what the state can do is really promote in its policies. How can we promote equity? You know, you have to focus on it. You have to focus on it. And then the status quo and the flow will just lead to more inequity. So as far as homelessness, I don't know if Connecticut has an interagency council on homelessness or a state agency that focuses on homelessness. But just as HUD has at least said in one way, you have to be looking at this as part of your applications. Really make that a focus in terms of funding. You have to show, are you going to address this? They should set some benchmarks in the homelessness response system or for agencies serving people experiencing homelessness, for everyone, but for our context, set some benchmarks to move towards equity and then hold people accountable. So the data has to be there, but first it has to be the will and the enlightenment to look at that.
Great, thank you, Bobby. I know some of the comments in the Q&A are just frankly that you're giving people so much to think about that they haven't even are able to formulate their questions into words. But I think one of the concrete questions I can answer is, yes, we will be making this presentation available to you all. We're also recording this and we'll make the recording available via link. So stay tuned for that. But I know others will want to review this again and also share it with some of their colleagues, Bobby. The one thing I did want to ask, one of the things that we've seen as we begin to look at COVID test data among our homeless population in our state is, despite the fact that we decompressed our shelters as far as we can tell in a fairly equitable way, we still are seeing higher rates of COVID positivity. Again, very low numbers of COVID positivity in our homeless population overall, but of the positive cases that we've seen, a higher rate among African Americans and Black people in our homeless system. And I'm curious what you think. You mentioned a few of the factors that may contribute to that, but what do you think is driving that, and what can we do to figure out how to make sure that we're protecting our homeless population from COVID in an equitable way?
Yes, thank you. Well, Connecticut has an advantage in that it is a Medicaid expansion state, so poor people have access to health care. So that's not true all across the country, so that'll be one thing. I think we do need to really promote universal testing among people experiencing homelessness. That's CDC's recommendation, but tests as a nation, we don't have a coordinated testing strategy. So that's likely not to happen. And then what we're doing is, with the hotels and removing people from congregate settings is really, really important. One thing, it's not so much to prevent infections because the conditions of their lives may make it more likely that they will get infected. No matter what a shelter does, and at least nationally, African Americans are more likely to be in a shelter than they are to be unsheltered. That may be driving some of it. So just being aware of that and giving extra measures to shelters, extra resources so that they can do what they can to reduce the transmission, promote equity in that sense. I will also add that the steps that we've taken as far as removing vulnerable people from congregate settings is not something we should. After this pandemic, there's no real good public health reason to retreat from that. There may be ideological reasons or even budgetary reasons, but from a public health point of view, we should not be putting people who are at high risk in congregate settings. There's a flu season coming up. There's all kinds of transmission of communicable diseases year round. So the more that we can promote universal access to housing and healthcare, we will be promoting equity.
Great, thank you, Bobby. I know we're running out of time here, and I just want to say on behalf of all of us at CCH and our entire coalition, Bobby, this was amazing, truly amazing presentation, and I really thank you for being with us today. Bobby, I know there are a lot more questions. I suspect people will be reaching out to you as well just for more information, but really thank you so much for your words, your incredible information, but also your leadership at the national level on these issues. And just want to thank you for your partnership and your efforts here today. Want to turn now to just close out the session by saying we have more to come, and it'll be tough act to follow, to be honest, with Bobby's presentation, but we have now a 2-hour training for McKinney Vento liaisons. Bobby did talk about inequities in education. One of the things we can do is ensure that our schools are doing their part to provide for the education, as well as to identify young people who are experiencing homelessness. We have a session at 3 o'clock looking at youth, particularly minor homelessness among under 18-year-olds, and then join us for a happy hour at 4 o'clock virtually. And then tomorrow we have a great plenary session, a conversation that I think is a great continuation from what Bobby spoke about here, a conversation on how housing segregation leads to the over-policing of communities of color, the criminalization of homelessness, as well as mass incarceration, which then subsequently can lead to further homelessness and a revolving door between prisons and homelessness. So please join us tomorrow for that plenary session. But again, I'll close this by just thanking you again, Bobby, for joining us today. And thank you all for staying with us. So please stay tuned and continue to follow us on social media. Thank you so much.
Thank you.